Let's see about cervical carcinoma, that is CA cervix. In India, CA cervix is the second most common gynecological malignancy. And the HPV vaccine is considered to decrease the incidence of CA cervix by about 90 to 100%. So, those vaccines are very effective against CA cervix. Coming to the incidence, CA cervix is the second most common, followed by CA breast. CA breast is overall the most common, and CA breast is followed by CA cervix, which is being the second most common. Next, coming to the epidemiology. CA cervix is most commonly found among women of age around 45 years and those who are sexually active. Coming to the pathology, grossly the different forms are exophytic, ulcerative and infiltrative varieties. Exophytic, it arises from the ectocervix and it has a cauliflower like appearance. Ulcerative, it mostly involves the vaginal fornices. An infiltrative type, which is also called as endophytic type, this is found in the endocervix. So, this causes expansion of the cervix and the cervix becomes barrel shaped. These are the gross varieties. Now, coming to the histopathological varieties. The most common is squamous cell carcinoma, which constitutes for about 80 to 85%, and these arise from the ectocervix. This is because the ectocervix is lined by squamous cells, whereas the endocervix is lined by the columnar cells. And this squamous cell carcinomas can further be of many types, which are large cell, and in large cell they can be keratinizing or non-keratinizing. Small cell carcinoma, which has a very poor prognosis. There can also be verrucous carcinoma. Next, neuroendocrine tumor, which is highly aggressive, and glassy cell carcinoma. These are the different types of squamous cell carcinoma. And the other variety is adenocarcinoma, which accounts for 15 to 20%. This arises from the endocervix because the endocervix is lined by columnar cells. So, this is of many types. One is endocervical, the others are endometrioid, clear cell variety, adenoma malignum, which has good prognosis amongst the adenocarcinoma. Then there can also be adenosquamous carcinoma, and there could be mixed carcinomas. So, and the source of metaplasia further turning into dysplasia and then into cancer is most commonly at the squamo-columnar junction. And the transformation zone. Transformation zone is nothing but the zone between the old squamo-columnar junction and the new squamo-columnar junction. Coming to the mode of spread, this spread can be either direct extension or through the lymphatics or hematogenous through blood. Direct spread, it goes to the adjacent structures like the vagina, body of uterus and the parametrium. Next, the lymphatic spread is to the primary group of nodes and the secondary group of nodes. The primary group include the parametrial nodes, obturator nodes, iliac nodes, rectal and sacral nodes, and the secondary group of nodes are common iliac, inguinal nodes and para-aortic nodes. Then the hematogenous spread is usually late and it is through veins. To the lung, liver or bone. Next is the staging of cervical carcinoma. The staging of cervical carcinoma is basically clinical staging. So, this is most commonly done by clinical examination. So, the staging, CA cervix is majorly divided into 4 stages: stage 1, 2, 3 and 4. The first stage in turn has 1A and 1B. This 1A is further divided into 1A1, 1A2 and this 1B into 1B1, 1B2 and 1B3. Next is stage 2. 2 is further divided into 2A and 2A into 2A1 and 2A2 and the next is 2B. Then the stage 3. Stage 3 has 3A, 3B and 3C. This 3C is divided into 3C1 and 3C2 and stage 4 has this stage 4 has 4A and 4B. These are all the stages of cervical cancer. Now let us see each stage one by one. First is stage 1A1. So 1A1 is when the stromal invasion is less than 3 mm in depth, whereas 1A2 is when the stromal invasion is from 3 to 5 millimeters of depth. This is 1A. 1B has 1B1, 1B2, 1B3. In all these cases, the invasion is more than 5 mm depth, and here it is divided based on the size. The size in 1B1 is less than 2 centimeter in greatest dimension, 1B2 is 2 to 4 centimeters, and 1B3 is more than 4 centimeters size in greatest dimension. And the one overall is when it is limited only to the cervix. And the second stage is when it extends beyond the uterus and it is limited to upper 2/3 of the vagina. So, this 2 has 2A and 2B, and 2A is nothing but when this 2A1 is when the invasive carcinoma is less than 4 centimeter in its greatest dimension, and 2A2 is when the invasion is more than or equal to 4 centimeters, and both these cases there is no parametrial involvement. Whereas 2B, it can be of any size, but there is parametrial involvement. Next is stage 3. Here the CA invades the lower 1/3 of vagina, extends to the pelvic wall, or it obstructs the ureter causing hydronephrosis, and there is nodal involvement to the pelvic or para-aortic lymph nodes. So, now 3A. 3A is when the CA involves the lower 1/3 of vagina, and there is no extension to the pelvic wall. 3B is when it extends to pelvic wall and or there is hydronephrosis, and 3C is involvement of the lymph nodes, in which 3C1 is involvement of the pelvic lymph nodes and 3C2 is involvement of the para-aortic lymph nodes. Next is 4. Stage 4 is when it extends beyond the pelvis and involvement of the bladder or rectum with metastasis, in which 4A is when there is spread to adjacent pelvic organs, and 4B is spread to distant organs. So, this is the overall staging of CA cervix, and the name of the staging is FIGO. FIGO staging of CA cervix. Stage 1, 2, 3, 4. 1 has 1A, 1B, 2, 2A, 2B, and 3 has 3A, 3B, 3C, 4 has 4A, 4B. And we have seen in detail about the staging. Here the stages 1A, 1B and 2A are considered as early carcinoma, whereas from stage 2B to 4B it is advanced carcinoma. Coming to the investigations, the specific investigations include colposcopy, hysteroscopy, cystoscopy, biopsy, endocervical curettage, all these are for seeing the extent of the tumor and to see the depth of the tumor spread. Next we take chest X-ray for any pulmonary metastasis, skeletal X-ray for bony metastasis, and we take intravenous urogram or USG abdomen and pelvis for seeing hydronephrosis, and proctoscopy for rectal involvement, and then the basic investigations are CT, MRI, FDG PET scan and PET CT. So these are all the important investigations, especially the CT, MRI and colposcopy, hysteroscopy and all that. Next, the differential diagnosis for CA cervix include cervical tuberculosis, syphilitic ulcer, ectopy of cervix, which is a benign condition of the cervix. Then there could be fibroid polyp or products of consumption in incomplete abortion. The products of conception. These are all the differential diagnosis. And what are the complications of CA cervix? The complications include hemorrhage, there could be increased pain due to conditions like hydronephrosis and pyelonephrosis. There can be pyometra or hematometra. In late stages, there can be formation of fistulas like vesicovaginal fistula and rectovaginal fistula. Coming to the cause of death, the important cause of death is uremia, which is the most common cause. This is because the metastasis occurs initially to the kidney, it affects the kidney causing uremia due to ureteric obstruction and the parametrial involvement. So the differential diagnosis includes cervical tuberculosis, syphilis, cervical ectopy, which is a benign condition, fibroid polyp or products of consumption in incomplete abortion. Then coming to the complications include hemorrhage, increased pain, pyometra or hematometra, vesicovaginal fistula and rectovaginal fistula. These two fistulas occur at a later stage. Then the cause of death, the most common cause of death will be the uremia because of the involvement of kidney being the first site of metastasis. There is obstruction of the ureter and the parametrial involvement causing hydronephrosis, in which the infection supervenes and thereby causing uremia. The other cause of death include vaginal bleeding, sepsis, cachexia and metastasis to the distant organs. Coming to the management differs for various stages of CA cervix. The management for stage 1, which has 1A, 1B, 1A has 1A1 and 1A2, 1B has 1B1, 1B2 and 1B3. Here for stages 1A1, 1A2, 1B1 and 1B2. The primary modality of treatment is surgery, which is hysterectomy, along with pelvic lymph nodes dissection. Whereas for stage 1B3 and from stage 2 to 4, the treatment modality is concurrent chemotherapy and radiotherapy. So, this is a basic management. Lastly, coming to the 5-year survival rate. The 5-year survival rate for stage 1A is around 95%, for stage 1B is around 80%, for stage 2 is about 65%, stage 3 has about 40%, and stage 4 is only about 14 to 15%. These are the 5-year survival rates for different stages of cancer cervix. So, this is all the most important points about cancer cervix. Thank you.